Hey all, this is our video on psychotherapies, introducing them, seeing how the varying different approaches agree, disagree, how they treat the varying disorders, how successfully they do that. So that's what this video and the next are going to try to tackle. Two things before I get started. One, we're going to say that this computer process works. We've been having issues with YouTube, you know that. So hopefully this is going to be something that will kind of work for us this go around. I am also going to give an advanced apology. Miss Georgia Bulldog is here at my place for a couple of weeks, and she is feeling particularly ornery today. So if she barks in the background, you've got some unintentional comedic relief. But hopefully that's all that she will do. So we'll see. In terms of just introducing all of this, when we look back at how it is that mental disorders have been treated in the past, it's been done in a very irrational way. A lot of the time, patients who were treated for mental disorders were just subjected to very, very, very strange and dangerous and deadly kinds of treatments when it came to the disorders that they faced. Hang on one second. So if you think back to even just the intro to mental disorders, we talked about how there were some individuals that underwent psychotherapy that involved having holes drilled into their head to rule spirits that were causing them to behave in such ways. So even in those circumstances, we can see just how unpleasant many of the early treatments for mental disorders were. Even up until the 50s and 60s, you had things like a lobotomy, where people had their frontal lobe severed from the rest of their brain to kind of help facilitate a dulling down of emotional responses from people. John F. Kennedy, his sister Rose, actually underwent that kind of surgery. His parents were very concerned by her emotional outbursts. What it really just turned out to be was just the up and down mood swings of a girl going through puberty, but they didn't want to deal with the hassle of the possibility of her having an outburst in public, because JFK's dad was in public life, so they had her lobotomized as a result. So you can see in terms of these treatments, it wasn't until there was a real big effort in the 1820s by Philippe Pinel and Dorothea Dix to really attempt to find more humane and caring ways to treat those who were mentally ill. But as I said, even the stigma of mental illness stuck around and caused great difficulties for people well into modern times. And we've all discussed how difficult it is for people with labels that involve mental disorder to be able to interact with everyone around them on a daily basis and not feel as if they're being judged in some manner. So let's do some breakdown in terms of terminology for therapy in general. So psychotherapy involves any kind of emotionally charged interaction between a trained therapist and a patient seeking that therapy, and it's a confiding interaction. So by that we mean that they keep confidentiality. What the patient shares with the therapist stays with the therapist. Now, a subset to this is biomedical therapy, the use of drugs or other kinds of physiological procedures that are attempting to implement something on the nervous system specifically to help, quote unquote, cure the psychological disorder. For most therapists out there, an eclectic approach is going to be used. So by that we mean various forms, whether it be cognitive therapy and biomedical therapy, or humanistic therapy with biomedical therapy. What they attempt to do is really individualize to a client's unique problems and then create the therapeutic approach from there. So we are familiar with these four theories, these four perspectives. This is nothing new for you. You've learned about these guys since Unit 1, all the way back in August. So this shouldn't be anything that is being provided to you in terms of information that's really out of the blue or different than what you've been shared with before. If you understand these perspectives well, their therapies then will be pretty easy to follow in kind. So let's look first at psychoanalysis, because Freud was one of the first to attempt to study mental disorders. And so he is going to create psychoanalysis to try to treat the emergence of mental disorders. So you can see his famous couch. since psychological problems, according to Freud and psychoanalytic perspective, come from these conflicting forces in the unconscious mind that often develop in childhood through trauma or unpleasant experiences, the aim of psychoanalysis is then to bring repressed feelings in the unconscious to the forefront of a person's conscious awareness to help them deal with them. So the goal of the therapist is to interpret what is going on in the unconscious mind in varying different ways. When, according to this theory, energy is devoted to attempting to release the conflict between the id, ego, and superego, we talked about those in the personality unit, then a patient's anxiety will lessen. They will become more aware of their issues and their struggles, and then they will be adequately able to deal with their problems. Now, the way to get into and tap into that unconscious conflict is through free association. Freud developed this where patients will lie on a couch and they'll simply just talk about whatever comes to mind, because Freud didn't want them to censor their thoughts. By censoring, what you did was you kept the unconscious as simply as that. You held that to yourself, and so by opening it up through word association or sentence completion, you were enabling him to gain access, a window into your unconscious to see what was going on, so then you could adequately treat it. It wasn't uncommon in psychoanalysis for a patient to exhibit resistance in opening up and expressing their emotions. That's a very common problem that anybody going through psychotherapy deals with. Many often don't feel comfortable sharing their innermost issues with complete strangers initially. We call this resistance or reluctance resistance, okay? Just that desire to avoid expressing emotions, refusal to do so. It becomes really important in the analysis of conflict-driven anxiety in particular for Freud. So if you see that a person is starting to resist your questions or your line of interpretations, you can latch on that, hey, that's kind of a problem that they're clearly demonstrating. So that's something we need to tap into further. That's something we need to address. If the person is resisting, that means that it is an issue of conflict for them, so it needs to be resolved. Pretty straightforward if you think about it. What can also happen in psychoanalysis is something called transference, where the patient can begin to, as they reveal those very personal, painful, innermost thoughts, they can start to develop a certain feeling toward the therapist. Often that involves transferring either positive or negative feelings they have toward people in their lives onto the therapist themselves. So many of you caught on to this as a vocabulary example. That you, if the therapist is asking you to discuss a positive relationship you had with a lover, somebody who was very significant to you, you begin to transfer those positive feelings from that individual in your life to the therapist. And the same can be said if you flip around. Let's say your therapist starts to attempt to address some issues you have with your parents, some very negative feelings that have built up over time. You begin to, because they continue to pull those out of you and pry those out of you, you begin to develop and transfer negative feelings that you had for your parents onto the therapist as well, because you're kind of developing an association between two things. So that's what we're referencing when we say transference. It's also possible for a therapist to do what we call counter-transference, where they begin to unconsciously take their own personal feelings and opinions and place them onto you. So if, for example, you were to, resemble their sister, their younger sister, they may begin to feel protective of you unconsciously because you remind them of that girl. And so as a result, they begin to develop certain feelings toward you that are other than a strictly client, patient therapist kind of relationship. So there's that as well. Now, some criticisms for psychoanalysis. It is really hard to explain and prove, or even to disprove for that matter. How do you really know that an unconscious exists? How do you know that a person has constant inner turmoil? What if it isn't something else that's going on? How can you thoroughly prove or disprove this theory? The answer is you can't. You've heard me make this reference, and it's slightly crude, but it's something that really helps to get the point across. You can't have someone carry out a urine test where they urinate into a Dixie cup. You take a sheet of litmus paper in there, you dab it in, and you say, yep, you've got unconscious inner conflict. It's not something that we can do within the field of psychology, and we are so science-oriented anymore. It's very difficult for us to fall in line with psychoanalysis wholeheartedly. The other thing to keep in mind is that psychoanalysis takes a really long time to work through, and it's really expensive. And so for many, it can end up just sapping them of a great many resources in terms of their time, their emotion, their energy, their money, and so that can be a big detriment too. Now, current theories within the field of psychoanalysis would then be called psychodynamic. We've referenced that before in personality. Those that were influenced by Freud, but who kind of alter some of his theories and thought processes. In current psychodynamic theories, it is a face-to-face setting, and what they attempt to do is more so understand symptoms and themes across relationships in particular for the patient's life. So what they're going to focus in on is if you're doing free association and you provide some level of negative feeling toward a sibling, they're going to try to take a look at that and say, all right, what's going on there? Why has that developed? Tell us about childhood experiences. Describe what's occurred, so that way they can focus in more on what kind of therapy is necessary. They also look to do interpersonal therapy. This is a variation of psychodynamicism in the fact that it's very effective in treating depression in particular, because what it is attempting to do is focus on relief. How do you gain relief right here, right now, in the present? Not necessarily this overarching behavioral change to you and your personality that can take a very, very long period of time to develop. Moving off to a different area, then we're going to talk about humanism and those kinds of therapies. Humanists, remember, they are all about self-actualization, reaching our full potential, our unique abilities, as you know, each of us have. And so what they're going to try to do is help people grow in that awareness and acceptance of who they are, flaws and all, warts and all. So that's important to recognize. So what humanists are going to look at then is person-centered therapy, okay? This is very much the offshoot of Carl Rogers and his argument of being fully functioning and having unconditional positive regard for yourself. So the therapist is going to listen to what the patient voices in terms of what they need, and it's going to be done in a very accepting, loving, open, non-judgmental kind of way. Because remember, for many who deal with mental disorders, they feel as if people make judgments over them. Important people in their lives, family, friends, it's very difficult for them to feel normal in any way and to have relatively normal relationships with other people. So by doing this in a very accepting and non-judgmental way, it enables people to address their problems in a productive and positive kind of way. Rather than focusing in on what is wrong with them, they can work toward helping to focus in on what is right with them. And so what the therapist does is they operate on active listening. They echo, restate, clarify what it is that the patient is attempting to say and what they're thinking, so that way they acknowledge what the patient's expressed. So if you, as my patient, for example, were to be discussing how it is that you feel as if you are a burden to your family because of the struggles that you go with on a daily basis with your depression, I, as a humanist, would say in terms of active listening. So what I'm hearing you say is you feel as if you are placing a really big weight on your family because of what it is that you go through. Tell me a little more about that. Explain to me what you're thinking and why you feel that way. Purely by rewording what it is the patient has shared with you, they feel accepted. They feel as if you understand them and that you're not judging them. And that has a really, really positive result for people with depression, for example, or several other kinds of disorders as well. Now, On the flip side of this, we have behaviorism. This is very action-oriented, very, very much attempting to take a look at the person's maladaptive actions and adjust those to make them no longer maladaptive. So this attempts to apply learning principles, classical conditioning, operant conditioning, to eliminate unwanted behaviors. Give me 1 second, I'm going to go deal with Georgia. Okay, so in terms of just extenuating this out further, extending this out further, to treat phobias or sexual disorders, for example, these kinds of therapists, they're not going to delve into, these deep-seated unconscious conflicts. They're not going to be looking for these inner terrible causes. All they're going to do is say, look, here are what the behaviors are. This is how we can go about attempting to address them. So there's no delving into inner kinds of struggles. In terms of different kinds of behavioral techniques, we have classical conditioning. One is counter conditioning. This is very successful with people with phobias, because if you think about it, your phobia was classically conditioned within you. The previously neutral item, whatever it happened to be, spiders, snakes, clowns, whatever, got paired with something that evoked a natural response from you of fear. And so you developed that classically conditioned response to it. So the way to address it then is counter condition yourself. Alter and readjust the learned response to no longer having a response. Okay, so this is a procedure that tries to condition some kind of new reaction to that previously learned stimuli, that CS, that triggered the unwanted behaviors in the first place. So it's based on some levels of classical conditioning, but there are also two subsets to counter conditioning. You can do exposure therapy or you can do aversive conditioning. Okay, so let's take a look at these things. When you look at exposure therapy, it's exactly as it sounds. You attempt to basically prevent the patient from being able to escape the thing that they fear. So they cannot get away from it, they cannot avoid it. You expose them to it through some level of repeated kinds of lessons. Because the more you habituate them to that item, the more that you expose them to it and make them aware of it, and that it is no longer presented with the thing that used to evoke, that naturally evoked the fear initially, it's no longer something that will become scary. So best example I can give you is the video we looked at in class of the big burly guy that has the very overwhelming phobia of dogs, and how he was just beside himself when he was presented with a puppy, crying, shaking, running away, cussing. He was very, very, very emotionally reactive to that. So what the therapist was doing was exposing him to the thing that causes him fear, that puppy, forcing him to pet it, forcing him to recognize that it is not something to be feared. It is no longer presenting that item that caused fear from him initially. And so that is the way that you can get over the fear itself. Just constantly, repeatedly presenting yourself with that item, with that conditioned stimulus, so that way you no longer have the fear to it. It's going to involve you being presented with these things in real or virtual environments. It is possible because our brain cannot distinguish between virtual reality and reality. If I were to stick you into a virtual reality simulation where you're riding a bike, the same part of your brain that would operate for that would operate for you physically riding a bike. So we can complete exposure therapy in scenarios where it is a real object and a real item that's presented to you, or it can be done in virtual therapy in order to help the person. We use this a lot in post-traumatic stress disorder, for example. Now, systematic desensitization is a kind of exposure therapy, because basically what you're doing is you're trying to associate, you're trying to counter condition the undesirable response in a relaxed, pleasant state. So let's say, for example, you have a fear of spiders, as is presented in this visual right here. What they would do is they would put you into a nice, relaxed state of awareness, and they would present you with that thing that causes you anxiety and fear, and they would gradually increase the amount of that exposure over time, systematically attempting to desensitize you to the thing that causes you fear. So you can see in this visual, let's say at first you show a picture, then you force the person to feel the picture and touch it. Then you take a real spider, and then you bring it ever closer, 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 and you require the person to hold it over time. So we've presented it to this person in a very relaxed, pleasant state, and so they no longer have any issues because they're in a very different kind of emotional setting for them to feel any level of anxiety or discomfort from that item. Sorry, she's still being fussy. If you can't tell, there she is, back over on the couch. So let's move on then, and let's talk about aversive conditioning. Aversive conditioning is where we attempt to take the item that has some kind of undesirable factor to it, and we try to associate it with an unpleasant state or unwanted behavior. So let's say, for example, that you struggle with alcoholism. This is one of the ways that we can attempt to treat you for that, because what you do is you put a drug that evokes nausea, okay, causes a person to get sick, in the alcoholic drink the person ingests. And so what ends up happening is it's basically taste aversion. The person becomes sick or ill after ingesting the alcohol, and so they start to develop an unpleasant association between the alcohol and getting sick, so they will no longer do it anymore. So this is relatively speaking kind of successful in terms of helping to get people to kind of tone down on their drinking. I mean, any of you that are familiar with people who struggle with alcoholism, oftentimes hangovers just are not enough. But if you repeatedly pair, that getting sick feeling just right away, it can end up being very successful in attempting to get rid of those maladaptive behaviors. Now, in operant conditioning, what we have is behavior modification, but it's going to be done through reward, okay? More so than anything else. You're going to reward the desired behaviors, the ones that are considered to be acceptable or normal. And so, undesirable ones are just kind of punished out, essentially, or attempted to be, at least. Many scenarios that can be factored into operant conditioning. Any of you guys that have ever gone through kindergarten and you got stars on a chart, or you got to be student of the month for something, or student of the week, or anything along those lines, you know that those rewards encouraged you to carry out certain actions. Now, we've taken a look at some studies with autistic children, kids who struggle with that particular developmental disorder, and many kids who were very withdrawn, non-communicative, that just struggled mightily socially, they were able to be successfully trained to kind of move away from that behavior and move toward desirable behavior by essentially providing them with reinforcements, with rewards, or removing those. So that's something to keep in mind, that sometimes rewards can have very, very powerful consequences in altering people's behavior. So what I was referencing with the gold stars is something that we call a token economy, okay? In institutional settings, therapists can create some kind of structure where a patient gets tokens and they can exchange them for some sort of earned reward, whether it's certain privileges, treats, things along those lines. It's not uncommon for you to see token economies in hospital settings, but as we've referenced, it's also possible to see them in school institutions as well. Now, with that, then we're going to move to our last look at cognitive therapy. And then I'm going to discuss some stuff with the biological, the biomedical piece with the drugs. With cognitive therapy, what you're attempting to do is adapt ways of thinking. Because cognition is all about thought processes and their influence on our actions, it makes sense then that cognitive therapists are going to attempt to address the maladaptive thoughts that people have as a result of their disorder. So, in looking at this visual, for example, you can see that if, a person loses their job, there are two different ways of kind of taking this in terms of your internal beliefs. One is, I'm worthless, it's hopeless, I'm never going to be successful in my life, and so therefore you can end up developing depression as a result of those thought processes. On the flip side of things, you could say, my boss is a jerk, I deserve something better, and as a result of those thought processes, you can end up being more inclined toward being a bit of a go-getter, so to speak, and trying to go out and branch out and do something better with your life. So, cognitive therapy. This is Aaron Beck and Albert Ellis. These two gentlemen are going to come back up in AP review for the exam. I can guarantee you that, so you want to know who those men are. Beck suggested that depressed patients believe that they can never be happy, and therefore they associate their actions, whether those be minor failings or even major ones, as cause for their depression. So, because their thought processes lead to certain actions, that's what causes the maladaptive behavior. Okay, so you had to get to the cognitive process. You had to change that in order to enable people with disorders to improve, to get better, especially people with depression. And so this change is brought on by what he referenced as gentle questioning, attempts at trying to pull out certain aspects of a person's thought processes if they are struggling with depression or anxiety, for example. Now, it is possible too, when you look at depression in particular and cognitive processes of addressing it, to train patients that have depression to record positive events in their life. So making them write out something that was good that happened to them and relate how they contributed to that good event occurring. And so when they started to do those things and getting the people to address those particular actions, they showed lower depression scores as they progressed. So it really is true that focusing on the positive and how you contribute to positive things happening in your life, that internal locus of control, that really can matter when it comes to getting over and properly addressing depression. Now, stress inoculation training. It sounds really weird, but basically what was attempted through this particular type of cognitive therapy was to train people to restructure their thought processes when they're in stressful situations. We're all aware that many stressful occurrences can trigger disordered behavior. So, best way to do it then is to alter how you think about stress, to alter how you react to it. So, an example of this would be for a test. Relax, the exam may be hard, but it will be hard for everyone else too. I studied harder than most people. Besides, I don't need a perfect score to get a good grade. So purely just by restructuring your thought processes when it comes to stress, that can alleviate some of the maladaptive behavior. In extension to this, you kind of have a little bit of a combination, as if we haven't made any of this at all confusing or heavy in terms of content, cognitive behavioral therapy. So you are looking at adjusting the thought processes and the actions. So that's why it's cognitive behavioral. You're attempting to combine both of those areas. One other way that you can take a look at things is group therapy, okay? Normally it's going to consist of about 90-minute sessions that will be with 6 to 9 people, and that helps to offset some of the costs that therapy can place on a person who's attempting to get better. And it can also help people benefit because they start to recognize that there are other people out there that have similar problems. They're not by themselves. They're not alone in the struggles that they face. And for many, that can be very important. The other thing that you can undergo is family therapy. This is an attempt to get your family incorporated into the efforts that you're making to get better. A lot of people struggle with believing that their family and friends don't understand them, that they don't get the disorder that they are struggling with. And so by undergoing family therapy, you can try to help improve communication and get some facilitation toward positive relationships with those people, so that way they can better understand how you feel and you can better understand how they feel in interacting with you as well. So the last piece that I'm going to take a look at on this, if it'll pop up for me, is the biological therapies sheet. Now, this is going to look a little small for you, but unfortunately this is just we don't really have a PowerPoint that can go along with this, because it's very cut and dry and straightforward and just kind of boring, if I'm being honest. So this is what your sheet of notes will look like, and so I'm just going to very quickly run through these for you, just so that way you have the information, and then we'll discuss them a little more in depth in class. So let's talk antipsychotic drugs. These are typically used for schizophrenia. However, it is an uncommon, it's not out of the ordinary for you to see some individuals with psychosis involved in their manic episodes, to see these prescribed for people with some bipolar disorders and variations of that. Some forms that you may be familiar with: Zyprexa, clozapine, it's Clozaril as the over-the-counter name, Thorazine, Risperdal, Seroquel. So this is, anytime you hear those terms, they're referencing antipsychotics. What they're attempting to do is block serotonin and dopamine. We know that a major cause of schizophrenia is too much dopamine being produced. So an antipsychotic attempts to block that. It acts as an antagonist to basically prevent the overabsorption of that dopamine, to lessen the hallucinations and the delusional experiences. It's typical for you to see results in 4 to 6 weeks. That is a very common result time frame for the biological, biotherapy piece to all of this. It takes several weeks for medications to get into a person's system and to really go to work. Unfortunately, there are a lot of side effects with antipsychotics, and so that's why it is very common for you to see people who stop taking their antipsychotic meds if they have schizophrenia, because they just don't enjoy the way that it makes them feel. They're very sluggish. They can end up having lowering of white blood cell count, so that can impact their immune system. They can develop involuntary body movements that we call tardive dyskinesia, so body tics. Facial tics, things along those lines. And they can gain a lot of weight as well because of the drug, because serotonin, we know that's involved in appetite as well. So a lot of the side effects just are not worth it to many who end up on antipsychotic drugs, and that's why they typically end up stopping it. Now, if you move on to anti-manic drugs, these are specific for bipolar disorder. These are either lithium, or they call them anticonvulsant meds. Depakote. Depakote is one that is a little bit more prevalent than lithium, mostly just because lithium is incredibly powerful. That's over here on the side effects piece. You have to be very, very, very careful, because lithium is toxic. I mean, lithium is found, for example, in batteries that you use in your everyday electronics. So you've got to be very careful to watch the amount of lithium that's being put into a person's system, so it doesn't get to toxic levels. The anti-manic drugs are very effective in reducing the manic end of bipolar spectrums, and you can typically see results with these in about a week. Now we go to antidepressants. There are two specific types of antidepressants out there, ones that are called SSRIs and the other is SNRI. An SSRI stands for, get ready for this, selective serotonin reuptake inhibitor. I'll say that again, selective serotonin reuptake inhibitor. So what they're attempting to do is stop the reabsorption of serotonin. Remember, we know that our neurons, when they fire out those neurotransmitters, they reabsorb what doesn't end up being used when messages are passed on along down the chain, and we call that process reuptake. We also know that depression often has a result of too little norepinephrine and serotonin in the brain. So by blocking the reabsorption, by blocking the reuptake, it allows the serotonin to stay out in higher levels and build up to stabilize the person's mood. SNRIs, on the other hand, these are going to work for serotonin and norepinephrine. So These are serotonin and norepinephrine reuptake inhibitors. That's what the SNRI stands for. With either of these drugs, you're going to see results within 2 to 4 weeks, and unfortunately, it's kind of trial and error when it comes to determining which one works best for you, whether it's an issue of serotonin or whether it's an issue of serotonin and norepinephrine. SSRIs that you're probably familiar with, Prozac, Zoloft, Celexa, Lexapro, all very commonly distributed out there. SNRIs, you see a lot of commercials for Cymbalta or Effexor. Those are SNRIs, so those deal with the serotonin and the norepinephrine. As is the case with any medication, though, there are side effects. You can get dryness, cotton mouth, basically. There are issues with constipation. It can slow down the digestive tract. You can develop headaches. Very frequently, it can cause those. And it can also lead to weight gain. It's not uncommon for you to see people struggling with depression once they're placed on meds to start gaining weight. Anti-anxiety meds, these are a little different because what they're going to attempt to do is reduce the intensity of the response that your brain has when it's signaling punishment or frustration, okay? When we have unpleasant things happen to us, we feel as if those are punishments. And when we have lots of stress, we can get frustrated very, very easily. So what anti-anxiety meds like benzodiazepines attempt to do, these are Valium, Xanax. Xanax, you guys are probably very familiar with. That's a very commonly prescribed anti-anxiety med. There's Ativan, Librium. What these try to do is lessen the reaction that you have to a situation where you would typically kind of over-respond or overreact in terms of punishment or frustration. You're going to typically see results from these in about a week, but the problem is you've got to be very, very careful. Doctors try not to prescribe these for extensive periods because they are very easily abused in terms of dependency. People can become very dependent very, very quickly on these. And so they try to monitor them heavily when it comes to the use and abuse of anti-anxiety meds. But again, there are side effects. You have issues of drowsiness. They can make you feel pretty sleepy. You have a reduced ability to concentrate because what had previously caused you to kind of narrow your focus on things that you would overreact to, now it's reducing that reaction. So you can have some issue being able to concentrate and stay focused. You can be just very lethargic, tired, and you can, as I said, end up developing a physical tolerance to, or physical dependence and tolerance to the drug as well. Two other kinds of scenarios. You have ECT, which is electroconvulsive therapy. There's no real forms for it. It's used to treat, and in some cases, kind of successfully, severe depression. Okay, so what they do is they take electrodes, they place them to your temples, and they shock your brain with varying degrees of voltage, basically. They're attempting to pass that electrical current through the electrodes past your scalp into the brain with the hypothalamus specifically. They're trying to readjust your hormone levels. We don't know if this is what really helps to address the symptoms of the severe depression or not. I mean, the mood-altering effects, they are fairly immediate. We don't really know if this is a correlational relationship or a causal relationship. But as I said, it does have some level of success for those with severe, severe, severe depression. Using today's methods of ECT, there's very limited effect on memory. It used to be they would just throw a large amount of electrical current at the hypothalamus, and that could end up affecting the hippocampus and long-term memory storage as well. But they don't seem to notice that with current modern methods. But a lot of the people in the public really do still worry about the safety of that. It does sound very harsh, very severe, and so sometimes people have a tendency to shy away from it. Then you have psychosurgery. This is the last of the biological, biomedical kinds of pieces. This is stuff like a lobotomy or other kinds of efforts to address parts of the brain that have led toward disordered behavior. You heard me reference a lobotomy. I'm going to show you a clip of it when we get to class. Basically, what you do is you go in and you sever the nerves that connect the frontal lobe to the rest of the brain and its inner structures. And this essentially what it does is it kind of alters the way that you behave. There is permanent lethargy. So you're kind of just a sitting vegetable, basically, just no real emotion. You can be very impulsive, but very quick to anger as well. And there's a level of immaturity because remember, your frontal lobe is the thing that enables you to think and behave like an adult. It's constantly growing and formulating to create your personality. And so if it's severed, it's going to be stopped at that point in time in which it was formulating all of those neural pathways. So if you have a lobotomy when you're 13 years old, you're going to essentially have that level of maturity of a 13-year-old. So it's a very, again, another very severe kind of procedure, but it is one to keep in mind because it's in very rare circumstances still used today. So I know that this was a really long video. I know this was a lot to throw at you. Trust me, we are going to work in class with one another to break these down, talk about how they all work together, differentiate all of them because this is a lot to throw at you. But as is always the case, let me know if you have any questions or you need any clarification. And hopefully next time, well, Miss Georgia won't be such a big pain in the butt. See you later.